So it's my pleasant duty to welcome our good friend and who's also a member of the DFoot International, Robert Frykberg, who's an adjunct professor at the Midwestern University, Glendale, Arizona, United States, honorary professor of podiatry medicine at the National University of Ireland, Galway, medical director of the DM Prevent LLC, and also in the board of directors of the International Association of Diabetic Foot Surgeons. And Bob Frykberg is going to give a practical talk on uh, management of Charcot foot. On to you, Bob. You can stop sharing.
Okay. Hello, everybody. It's a pleasure to be with you today. This is an early morning, Phoenix, Arizona, and I'm very happy to be with you. It's always nice to follow Mike Edmonds, but it's also a difficult task. So I want to present to you a very basic approach to the diabetic Charcot foot. This is not an in-depth scientific lecture, so to speak. However, it's based on my many years of experience after seeing my first case of Charcot foot, believe it or not, in 1975. The first description of the pedal osteoarthropathy, what we now call the Charcot foot, was actually by Charcot himself in 1883, and he termed this the pied diabetique. Of course, his patients were afflicted with tabes dorsalis rather than diabetes mellitus. But the first diabetes-related case of Charcot foot was actually published by Jordan in 1936 in the Archives of Internal Medicine. He had been a prior Joslin Clinic fellow where I had trained. Now, as I said, I had had many decades of experience with the Charcot foot, and my first publication was with George Kozak, also at the Joslin Clinic. And this definition serves us fairly well even today. Neuropathic arthropathy is a relatively painless, progressive, and degenerative process affecting single or multiple joints due to underlying neurologic deficits. Now, we can parse the words, but I think most of us understand that this is, in effect, the underlying definition of the Charcot foot as we know it. Now, we know it's also a rare disease, meaning it's less than 1% incidence in the entire population. The largest study that we have is published by Svensson out of Denmark in the Danish population, and their incidence was 0.56%, so still less than 1% in the overall Danish diabetes population. And this is consistent with other populations as well, going back to Sina's early study from Joslin Clinic, which was 0.15%. Now, the Cofield study published in 1983 was actually a study on aldose reductase inhibitors. So all the participants had underlying neuropathy. So this is a well-defined population, and they had almost a 30% incidence. But generally, we all recognize that this is a rare disease affecting less than 1% of the diabetes population in general, at least as far as we know now. Now, it's a complex disorder based on a number of underlying metabolic perturbations, and we recognize the neurovascular school of thought and the neurotraumatic schools of thought. But this was a nice diagram put forth by William Jeffcoat and Fran Game back in 2005. And this was really part of the neurotraumatic theory, which was a prevailing theory in the early part of the 20th century, where we had that neuropathic foot subjected to trauma, and the increased force leads to fracture or dislocation. With continued weight bearing, you get this so-called vicious cycle that breaks down the foot, as we well recognize. But we also know, since Brower and Allman's work in, I think it was 1981, we recognize now the role of the neurovascular theory, or autonomic neuropathy as well, sometimes called now the inflammatory theory, where we have that osteopenic foot sustained fracture with the aggressive release of pro-inflammatory cytokines leading to excessive inflammation, rank L, NF kappa beta release, osteoclastogenesis. And we see how these two schools of thought, or these two underlying pathophysiologic entities, come together to come into that perfect storm, which we now call the acute Charcot foot. I think it bears repeating that we at least understand the rank L OPG axis here, and I'll try to explain it as best I can. We have that neuropathic patient, acute trauma, leading to an upregulation of pro-inflammatory cytokines and NF tumor necrosis factor alpha, interleukin-1 beta, leading to an upregulation of rank L, receptor activator for nuclear factor kappa beta ligand, as we can see here. Concurrent with the upregulation of rank L, we have the upregulation of osteoprotegerin, which is the decoy receptor, which is really the balancing act to normally prevent aggressive upregulation of rank L. Subsequently, the rank L combines with rank on macrophages, monocytes, and pre-osteoclastic cells, leading to an upregulation of NF kappa beta, which then leads to enhanced osteoclastogenesis, as we can see here, leading to that activated osteoclast, leading to the bone dissolution. Now, that's a very short, quick summary approach from a clinician, but I think it's still important for us to recognize the important role of the rank L, rank OPG pathway. Now, there are new theories and hypotheses underlying the pathogenesis of Charcot arthropathy, but we have to keep in mind, why is it so rare among neuropathic persons? There's neuropathies, not just diabetes, but TABES, Hansen's disease, leprosy. We see a lot of Charcot foot in neuropaths of alcohol abuse. So we see that very commonly. But what is the common link here? So we have to determine that yes, we can have Charcot in any type of a neuropathic person of any etiology, but are these diabetic neuropathic patients different from the non-diabetic neuropaths? Are the vascular, microneurovascular, and cytokine disturbances in CNA Charcot neuroarthropathy similar or different? We've seen from old studies, there's been a preservation of hyperemic response. There's variations of interleukin-17. We have the Wnt beta-catenin axis that's also altered, alterations of calcitonin gene-related peptide. There's monocyte alterations, et cetera. So there's a lot of underlying disturbances that have been noted over the last 20 years or so, but mainly in diabetic patients. And so my point is, does this remain the same for even non-diabetic neuropaths with Charcot arthropathy? We also recognize from some, I believe, very important papers, there are genetic mutations with single nucleotide polymorphisms, or so-called SNPs. This was put forth by Pitoko in 2009, Korzon-Borokowska from Poland in 2012. And this was related to OPG versus rank L SNPs. But are there also other genes involved? Are there other gene interactions? Is there interaction with the monocyte methylation genes, which was put forth very recently, or the Wnt beta-catenin genes? Can this be the unifying hypothesis across all neuropathic patients? This has not yet been adequately studied yet. So the problem also is that in almost all studies, all the measurements were taken after the onset of Charcot. You can't measure a putative cause after the onset of the disease, not with any great reliability. So are the microvascular cytokine alterations a cause or a consequence of Charcot neuroarthropathy? There's also a delay in time of development or initiation to diagnosis. So whereas a Charcot foot might have started weeks before diagnosis, does that come into play as well? So there are many, many underlying concerns, but still we have a much greater understanding now of the underlying etiology. But still, we have to get back to basics. So one of my favorite papers is this by J.T.H. Johnson, published in 1967. And he stated that the behavior of bones and joints in neuroarthropathy can be explained on the basis of the usual responses of these tissues to trauma, modified by the presence of decreased protective sensation. And that's it in a nutshell, basically, as we approach our treatment. So Lee Sanders and I published this graph many years ago, but it was put forth also at the additional stage 0 by Shibata back in 1991, where we introduced the stage 0 or prodromal period, that initial period of heightened inflammation after injury with no radiographic changes. Then we have the acute stage 1 development that we're all familiar with. These are the classic Eichenholz staging system. Then we have stage 2 coalescence, and of course stage 3 reconstruction, or the chronic phase. Now, there's no great identifiers going from one stage to the other than clinical parameters and perhaps radiographic parameters, but there are many different types of classification schemes that you can use, but these are basically the stages of natural history. But as we put forth in our Charcot consensus in 2011, the keys to early diagnosis are clinical suspicion, patient history, clinical findings, and radiographic studies. And Mike Edmonds had previously discussed some of this. So we have to have a very high index of clinical suspicion in that neuropathic patient. Then we obviously must take good control of the patient's history, ascertain the pertinent clinical findings, and of course, get your early radiographic studies, because as Mike had said, early diagnosis is really the key to success here. Early diagnosis is primarily a clinical diagnosis with that red hot and swollen foot. Inflammation, as we know, is the earliest and key finding. And it's often present after a very subtle injury. Many times there's no reported injury at all unless you really probe for it. And that's how we detect that stage 0 foot at the earliest point, where we're just seeing generally unilateral swelling without any other reason. And we need to keep this first in our mind, because this is the time that it's critical for us to make the diagnosis. When we see the midfoot collapse or rocker bottom, that's the hallmark of the Charcot foot, but that's when the deformity has already occurred. And many of us would consider that it's really too late to prevent deformity, of course, but we can prevent further deformity. And it's also our job to prevent subsequent ulceration, infection, gangrene, and limb loss. So again, critically important, we have a high index of suspicion in these neuropathic patients presenting with that generally unilateral inflammation at its earliest onset. Radiographic findings, I think we're all well aware of. There are many, many different types of findings, but remember, in stage 0, that prodromal stage, you're not going to see any radiographic changes. But this one in the center with the arrow is one of the earliest heralding signs, where you can see what you think might be a Charcot foot, but you don't see any gross radiographic changes. Look at the base of the second metatarsal. Even a simple 1 millimeter slip or subluxation to the side or dorsally or plantarly is diagnostic for a Charcot foot. Now, although we don't normally need to get adjunctive imaging modalities, when we diagnose these patients or we're very suspicious of a stage 0 Charcot foot, we might want to get adjunctive imaging modalities, such as bone scan, which is very sensitive, but of course non-specific, a white blood cell scan, a little better specificity, but still you can have false positives. A CT scan, it's useful for evaluating hidden areas, like I just said, that first or the second metatarsal cuneiform joint area. Looking for ankle or subtalar joint or intercuneiform dislocations. And we'll often get a 3D CT or a SPECT CT, as you can see there. But most of us recognize that when we're really suspicious, if we have MRI available, that's probably the most sensitive and the most studied adjunctive modality, as we can see in some of the images over here. but it's not specific really versus osteomyelitis. There are some subtle changes, but we have to be suspicious for that enhanced bone marrow edema, which is indicative of that stage 0 prodromal Charcot foot in the absence of clinical X-ray findings. So this is just one classification scheme that Lee Sanders and I put forth in 1991. Most common presentation is going to be your 2 or 3, which is really the midfoot, the Lisfranc's joint, or the tarsal metatarsal areas, or the naviculo-cuneiform joints. But remember, we can see presentation almost in any area. Probably the most difficult to manage clinically is with the ankle joint involvement, the pattern 4. Now, again, let's get back to basics here on treatment. This is not a new condition, as we well know. Now, this person was a very famous orthopedic surgeon, published in the Journal of American Medical Association in 1931, where he said treatment of this disorder, mainly dealing with tabes dorsalis, was early and adequate splinting, preservation of protecting musculature by physical therapy, and above all, earliest stabilization and alignment by conservative or operative means is the best way to approach these. I think this rationale still holds true today. So the general treatment goals: convert from active to inactive or the quiescent stage generally by offloading. Prevent further deformity. That is really our goal here. Provide protected ambulation once we feel it's safe to have them ambulate, and prevent recurrent ulcerations and instability. Those generally are goals of treatment. I think not many of us can argue with this. So our objectives: convert from active to inactive or quiescent stage. I believe non-weight bearing is, if not essential, critically important, because it can get rapid resolution of the inflammation and the edema. Immobilization, I think, is really critical, most often with a total contact cast, or at least a non-weight bearing cast. Some people believe that weight bearing with TCC is acceptable and fine. This was put forth by D'Souza in 2008 and corroborated by other studies. And it's okay, but I think you get the most rapid resolution by taking the stress out of that area. Surgery is traditionally not performed. Now, remember, going back to the 70s, surgery was not recommended much at all. It was considered taboo, although many of us were doing surgery back or a few of us were doing surgery back in the 70s. And remember, the J.T.H. Johnson paper came out in 1967, and he was recommending surgery with a good deal of caution. But we generally do not perform surgery in the acute stage unless you have an acute dislocation, as was put forth by Newman in 1979 and Lesko in 1989. Acute dislocations can be managed acutely with arthrodesis and stabilization. Acute dislocation, again, we often see that in the ankle, or more commonly in the talonavicular joints. There have been several reports of acute midfoot fusions. This is by Simon, published in 2000, but only 14 patients, and Mittelmeyer in 2010, only 4 patients. So we have to keep in mind that there's not a lot of good evidence surrounding the role of acute operative stabilization. But perhaps more commonly, especially in the US, is percutaneous external or circular stabilization to help manage the deformity and stabilize it at its onset. This is a very specialized approach, and it's generally not recommended unless you have a great deal of expertise in this type of operation, as well as with the Charcot foot. Remember, most surgery is done in the chronic stages, but we also have to pay attention to the adjunctive treatments in the acute stage. And these are the pharmacological treatments for the most part, but there's negative or inconclusive benefits as indicated in the literature. Certainly bisphosphonates, really not any good supporting evidence, although that was very much anticipated in the early 2000s. Calcitonin, as the group from Prague has shown might be a benefit. Denosumab, which is anti-rank L, has been supported with some minor evidence that perhaps it might help alleviate the inflammation with the acute Charcot foot. Nina Petrova from Mike Edmonds' group studied recombinant human parathyroid hormone and did not find this to be successful or of any benefit. TNF alpha inhibitors, anti-rheumatoid arthritis agents primarily have been suggested, but not provided any evidence. And of course, electrical bone stimulation has been considered, but no good evidence. So we have a lot of potential adjunctive therapies, but nothing supplants the basic therapy as we've already discussed. In the chronic stage, the quiescent stage, surgery can be performed as necessary. And this would be plantar or medial exostectomies or simple bone resections to remove high pressure points and bony prominences. Limited arthrodeses can be performed or major reconstructions. But again, with major reconstructions, you must use cautions because these are very complicated patients. They're neuropathic, and we know they're very much subject to complications. So again, it needs to be an experienced surgeon in an experienced center who sees a lot of these patients. And we must treat that operated foot as an active Charcot foot. So here's another simple algorithm. In the non-ulcerated Charcot foot, we provide for therapeutic footwear, bracing if necessary, and surgery if we have severe instability. In the ulcerated foot, again, we'll go back and provide for offloading, bring that back to a non-ulcerated foot. We'll provide for surgical intervention if there's chronic deformities or if we have instability, but our goal is to get that back to that non-ulcerated chronic Charcot foot. Another, hopefully this is not a terribly confusing algorithms, but let's say we have our Charcot diagnosis or referral. In this arm, we have the acute Charcot foot. And again, we just follow our age-old recommendations going back 4 decades or so, or even back to Steinman's recommendation in 1931, rest or immobilization with a TCC or removable cast walker, crutches, wheelchair, etc., plus or minus pharmacological therapy. Frankly, I rarely have had to use pharmacological therapy. Once it's stable, we provide for therapeutic footwear or bracing and chronic surveillance. We also know that many of these people will present with a chronic ulcer, whether they're chronic or acute, and then we just treat them again, as we said, with a TCC or removable cast walker with appropriate intervention if they're infected to try to get them old state with an intact skin envelope. And then we provide our stable therapeutic footwear or our bracing. If the patient remains unhealed with that chronic ulcer, then we move right over to surgery, whether it be exostectomy, bone debridement, arthrodesis, osteotomy. Sometimes amputation is necessary, and sometimes, especially formed unstable ankles. Even the Charcot Consensus Group in 2011 indicated that surgery is a primary consideration, and sometimes amputation of that foot after years of dealing with a chronic unremitting problem. Sometimes amputation is a hard decision to make, but needs to be made. So in summary, dealing with this very complex conundrum, if you will, you must have a high index of suspicion. And at the earliest presentation of that patient with and a history of trauma, think of Charcot foot at its earliest, hopefully in that stage 0 before deformity sets in. Use appropriate imaging techniques, usually an X-ray, and a high degree of suspicion is all that's required. Non-weight bearing is recommended at least in my point of view, immobilized generally with a cast or removable cast walker, and a very gradual return to weight bearing. And I emphasize gradual, because you can always reinstitute that inflammatory process, and always support the contralateral foot, which is also at risk. Provide protected ambulation with therapeutic footwear. Surgery as necessary, as we said, primarily in the quiescent stage. And I think most important is periodic evaluation and lifelong surveillance, because these patients are subject to all the other ills. And as we said, we've seen as early as a report by Steve Edelman in 1989, where you can have an ischemic Charcot foot that you must be very, very careful and recognize that just having a Charcot foot does not preclude the onset of peripheral arterial disease. Thank you very much for your attention. Hopefully that'll be a brief review and of some help to you all. So again, thank you very much, VJ.